Good morning, everybody. Thank you very much in joining this early bird webinar. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation, and I'd like to thank you for joining us this morning. Today, we'll be discussing cancer prevention, what's worth the effort. So before we begin, just a couple points. If you're having issues with your bandwidth or your connection, we have provided several phone numbers for you. Just push the little button next to your mute on the control panel. This menu will pop up and you can choose the switch to phone audio. As well, we'll be taking questions. This is only a 30-minute webinar, so if you do have questions, please get them in early, and we'll try to circulate them to the panel, and I'll do my best to make sure we get your questions answered, but please do be prompt and get them in because we do have 100 of you on the webinar today, and we want to make sure we answer the questions that you have. So as roughly 40% of all cancers are considered preventable, prevention is currently high on the political agenda. Vaccination programs, environmental policies, and supporting healthy lifestyles feature prominently all over the world, including within Europe's Beating Cancer Plan. When prevention works, it's a cost-effective element of any long-term cancer control strategy. Little is known, however, about the actual effects and causal links between preventative policies on cancer incidence and mortality. Evidence linking prevention to verified results is scarce and often unclear regarding which policies and programs work, and to what degree. How strong is the case for cancer prevention overall? How should prevention be incorporated into national cancer plans? And ultimately, what is the role of prevention in evidence-based health policy decision-making? And to discuss this and other issues that we have today, I'm very pleased to be joined by two extremely articulate and worldwide knowledgeable gentlemen. First, I'd like to introduce you to Thomas Hoffmacher, who's the research manager at the Swedish Institute for Health Economics. Thomas, good morning, sir. How are you? Good to see you.
Good morning. It's a pleasure to be here.
Yeah, thank you, Thomas. And we're also joined by Nikolai Pushkarov, who's the policy coordinator from the European Public Health Alliance. Nikolai, good morning, sir. How are you?
Yeah, good morning. Thanks for the invitation. Good discussion.
It's our pleasure, and it's great that you two gentlemen are here. So first, just to begin, Thomas, why don't you give us an overview of the report you just filed at the Swedish Institute? Because in your report, you say that up to 40% of cancers are preventable. What do you mean by that, and what is the context of that?
Yeah, exactly. So prevention is a big and a very important area of cancer control. And today, Nicola and I will only really talk about primary prevention, not secondary prevention. So primary prevention is really about trying to prevent people from getting cancer, whereas secondary prevention is about trying to detect cancer early. And usually when we talk about prevention, we just mean primary prevention. As you just said, around 40% of all cancer cases seem to be preventable. So there's a great, I would say, a massive potential there. Like if we look at the latest figures from the EU27, we had 2.6 million new cancer cases diagnosed. Preventing 40% of those, that's 1 million cases of cancer being preventable every year. And now, I mean, when it comes into primary prevention, it's important to also to keep in mind what are the factors, the key factors that are behind getting cancer, like the main risk factors. And let me just go through the top 10 list, because I think it's important to recap this. So just general top 10 list in Europe looks something like number 1 is smoking, and number 2 is still smoking, and 3 and 4 as well. So around 40% of all preventable cases are just related to smoking. And then in 5th place is UV radiation from the sun causing skin cancer. We have obesity, we have alcohol consumption, we have unhealthy diet related to both over and under consumption of certain kinds of foods. We have certain kinds of infection. And then lastly, physical inactivity. Those are like the risk factors that are preventable by individuals. Then of course you also have environmental factors, as you said, and occupational carcinogens. But so in general, smoking seems super important. But even, you know, if there seems to be the greatest potential there, doesn't mean that that's where we have the low-hanging fruits. Because when it comes to hard scientific evidence, and evidence on effectiveness and cost effectiveness, we see, or at least I see, sort of double standards. And I think the prime example is HPV vaccination, where we have solid evidence that is both effective and cost effective in girls. We knew this for the last 10 years, And we also know for the last 5 years that it's cost effective and effective in boys. European countries have been super slow in implementing those things, even though we have the evidence. And it's a bit interesting to see this, because for vaccination, just look at COVID-19 vaccine, we have high evidence standards. But then when it comes to other primary prevention measures, we don't apply the same evidence standards. We just say, let's put 1 million euros into an online campaign or mass media campaign to promote physical activity. But we're doing this almost always on a trial and error basis instead of based on exactly solid evidence.
Let me stop you there, Thomas. Thank you very much. Now, Nikolai, I'd like to bring you in. If we're looking at some of the points that Thomas has made about prevention, from your point at EFA, what categories or which fiscal behaviors would you guys insist, or at least would promote, to try and get better prevention measures? What would you like to see in cancer?
Yeah, thanks, Dwayne. And I totally agree with Thomas about the starting point, that indeed we should really be looking at primary prevention through the lens of risk factors. I guess we'd be having a slightly different sort of starting point, because when we look at the risk factors, you kind of clearly see that, let's say, 4 to 5 of the main risk factors, quite a few of the ones that Thomas mentioned, the risk factors for cancer happen to be exactly the same main risk factors as for other key NCDs, which altogether pose kind of the overwhelming burden of ill health in Europe, which include, of course, cardiovascular disease, type 2 diabetes, some respiratory disease. And well, in a way, I'm not sure if that's appropriate to say, but in a way, we're lucky with that, because in terms of when you're looking at it from a cost effectiveness point of view of primary prevention interventions, I would kind of see the question expand from what actions will help prevent a certain type of cancer towards what actions will help achieve societally optimal outcomes by simultaneously preventing a range of NCDs and including a certain types of cancers. And in a way, you could even put it further. It's about not just actions to prevent disease, but to create living environments that enable health and well-being. So it's not just for the sake of this disease reduction, but for promoting good health more widely. So by looking at this way, the range of co-benefits of policies expands quite significantly. And this is not just like an abstract point. I mean, there was a systematic review from 2017 showing a huge median rate of return from public health policies, like 14-1. And this is really huge. And it actually shows that many types of health policies are cost effective. However, there is indeed a kind of effectiveness hierarchy, if you wish, with the more cost-effective policy tending to be these population-level prevention policies, so focused on changing some of the structural incentives in society rather than those that address individual behavior. And well, I think, and I'd really be happy to further down in the discussion go more into that, but I think there's a good overview actually of what types of measures are cost-effective. They're kind of in the summarized quite well in the WHO best buys and other recommended interventions for the prevention and control of NCDs. It's a mouthful, but the document is very concise, and it relates indeed to policies like pricing, marketing, labeling. There's part of vaccination is in there, some screening, but which is already secondary prevention. Sure. But yeah, further down, really, I'm happy to look at this question, whether at the end of the day, it is good enough to have evidence whether a policy actually addresses a risk factor, or whether you need to show a direct disease kind of impacts, which I think needs to be taken case by case.
Thank you, Nikolai. I'd like to bring Thomas back in and start here with both of you. Thomas, you pointed out quite articulately that, of the top 5 disease areas, 4 are cancer prevention. You look at cancer rates since 1960, they've gone down by 70–80%. Is there a law of diminishing returns here, Thomas? Is, sort of what Nikolai is saying, would maybe some of these other more population approaches give us more bang for the buck? Or at what point do we stop seeing an economic benefit on trying to prevent?
I mean, I think the economic benefit never ends. You know, we published a study earlier this year showing that cancer causes costs of 200 billion euros in Europe per year. So, you know, trying to reduce the number of cancer cases will yield returns. The question is just, you know, what's the ratio of costs to benefits? I mean, we can do many efforts, and some don't require money. I mean, you can just do some law changes, like increasing taxation will not cost you anything. I mean, the lawmakers just have to make the change happen, right?
Sure. But I'd like to point out a pack of cigarettes in New York is $20. A pack of cigarettes in London is 11 pounds, yet people still smoke. So
exactly. And I mean, when it comes to smoking, we have seen a very positive development, like smoking rates going down broadly in the Western world. And that's a good thing. But it was really just a mix of strategies that was behind this development. And it's a bit difficult to point out exactly what were the key drivers, because we always had increasing taxation. We have different kinds of bans, different kinds of warning labels coming in. So we did a whole mix of things always at the same time. So it's difficult to disentangle what was really the key driver. I'm not saying that we shouldn't do those things. I think we should do all those things, because probably just choosing the right mix will get us there. But it's also...
Let me bring in Nikolai now. Nikolai, from your perspective in this mix, how would you, from a public health perspective, prioritize? What do you think we should be doing to pick the right ones, the right targets?
Yeah, and I think it is exactly that. It is a mix. There's not one silver bullet out there that's going to. That's kind of a tendency to hope that, well, you just do this one thing and, you know, kind of the house will fall down. You know, just like this one ideal move, and that will kind of solve it all. But I think that's a bit naive to say, because to think, because I mean, this is a multifactorial problem. So you cannot think that by just taking away one element, you will solve multifactorial issues. But within that, of course, and taking smoking as an example, I mean, the WHO clearly points out, for instance, that fiscal intervention is the single most effective measure when it comes to tobacco. That doesn't mean that if you only do the taxation, that everything follows from that. No, it is really this packaging approach, but maybe like more practically looking at what's now on the table, what the EU also from a point of view of competence can really act on better. I would say it would be tax fiscal measures, which there's still scope for that, also in tobacco across member states. So kind of really supporting on that. With alcohol, the same, some of the food as well. But I would also point out the huge capacity in terms of marketing. So the cross-border marketing more specifically, which is a pure EU competence. And here we are certainly in the area when we're thinking of alcohol and food, it is very, very under-leveraged. So these are, I would say, two priorities. But again, dealing with multifactorial issues, you cannot expect that one thing is going to solve them.
No, that's fine. Thank you very much. And I'd like to point out to our audience, we will be taking questions from, if you submit them. There's a little Q&A bar in your menu. Please feel free to pop that open, and we'll distribute the questions to our two speakers. And it's our pleasure to do so. Gentlemen, what do you think needs to be done to gather more evidence about the relative cost effectiveness of one prevention or another? What are the tools that we need to be able to distinguish what's the best way to spend societally? And what's the toolbox? Do we have the right toolbox now? Nikolai, I'll start with you this time. What do you think? What do we need?
Well, I think it's really important to really understand what data actually you need and for what, because there is quite often the supposition that you need to show direct effects on rates, let's say on cancer rates. But this is sometimes difficult to do. And I'll just give like one practical example. Like last year, the WHO published a case study of Russia looking at alcohol policy. So they implemented the right range of alcohol policies, and they followed really kind of with data very quite specifically over a period of 2003, 2018. They show a mortality decrease by 40% in men, 35% in women, They found that at moments where there was a higher intensity of alcohol control policies, the decrease in mortality was steeper. They found sort of associations with cardiovascular disease, liver disease, sort of alcohol-related injuries, traffic death, etc. But so it really kind of shows that these also quite steep declines in alcohol consumption, but they kind of point out, well, when it comes to cancer, even within this period, we were not able to attribute that because it develops over time. Now, and if you look at it from this sort of narrow approach, then you say, well, there's no evidence that these policies work because they haven't linked it to cancer. But I would say, is it really realistic to expect that this will not have that kind of addressing a clear risk factor for cancer will not have this effect? I think that's a very hard, tough argument to make. So I think we need to really look at what type of effect we need to show, and for what types of interventions. I think this is a very important question, so we don't get confused there.
So Thomas, from an economic standpoint, then how would you disentangle sort of the public health efforts from colonoscopies, for example? How would you directly try to look at the weight of the impact of those? Obviously, colonoscopies are very effective for colon cancer, but colon cancer is obviously also affected by alcohol consumption. How would we actually, how would you actually deal with that from an economic calculation, societal perspective?
Yeah, exactly. So it's of course it's a bit difficult because the main thing here is the latency period. You have some time where you have an exposure to the risk factor. So you smoke or you drink alcohol or you are exposed to, for instance, asbestos fibers. And then it just takes a very long time actually for the cancer to develop. For asbestos, the latency period is around 30 years. So you have been exposed 30 years ago, and now you get mesothelioma, which is a cancer of the lining of the lung, and to evaluate, to have studies that run over such a long time and really make the link from exposure of the risk factor to getting cancer is difficult. What we usually do is just look at the effect of a policy on the risk factor, and then we hope that, well, by decreasing alcohol consumption, by decreasing smoking, we will eventually also see reductions in lung cancer rates or rates of esophageal cancer for alcohol, for instance. So,
but the connection is still quite tangential then, from what you're saying. It's not a direct. It's still you're extrapolating out a long time to see these effects. It's quite challenging.
Yeah, exactly. It's enormously challenging. Like always, when you have this long delay between an exposure of the thing that really causes cancer and the time when the cancer materializes.
Well, let's try and make this more tangible then. Let's go back to your HPV example that you mentioned earlier. I mean, we know in France, for example, that 60% of women were unwilling to take the HPV vaccine. Okay, we know that for a fact. That was shown in data. Should we advocate then what the French government and the Italian government have done, put in laws basically saying you have to take these for prevention or you are not going to be able to go to school, for example? I mean, what's your perspective? I mean, let's take a hard line here and look at that. Would you advocate that perspective? I'll start with you, Thomas, then Nikolai, I'll go to you from a public health perspective.
Yes, so HPV vaccination, actually, those kids are already in school. They're around 11 years old when they're vaccinated, so you cannot really prevent them from going to school. But I mean, and that's at least my point of view. I mean, I believe in science. I believe in the evidence we have gathered, and there are so many studies on HPV vaccination and who actually now have done long-term follow-ups. So girls and boys that have been vaccinated 10, 15 years ago, that's when we started. And now we see just not a reduction in HPV then infection, but also we already start to see, was a study now in Sweden this summer coming out, see a reduction in cervical cancer rates. The evidence is there, it's strong, and the higher the rate of vaccination in young people, the higher the number of cancers that we can prevent.
So Nikolai, where do we draw that line between public health need and individual rights? What's that limit? Where do we put that?
Yeah, I mean, it's well, clearly HPV is also indeed included in the WHO Best Buy, so it's kind of it is an intervention which shows efficacy. I mean, I think it's I mean, it is not an easy question always, because on the one hand you want it to happen, on the other hand there's many factors also to take into account. So I think it's important, and I'm not a much specialized in this particular, because it's a question of how you actually make these things happen specifically around vaccination, so that they are also eventually really being fully accepted by everyone, etc., etc. So there's some way of of doing it now, I guess, with these sensitivities that really do not maybe only require the kind of the approach of making things mandatory, but really kind of creating the framework around it. And I would personally really not be able to say much more about the details there. But I think more generally, it's really about, and this really kind of also comes down to, yes, I mean, we have to look at the cost effectiveness, the cost benefit analysis, but at the end of the day, we also live, it is a kind of a point of politics as well, all of it, any policy that we do. And I think it's also a way, very importantly, how we present it. So, I mean, how we kind of increasingly looking at it is that, you know, prevention, public health policies, we really try to speak about them more in terms of, okay, we're creating these environments, these living environments that are actually there to enhance, to enhance and empower health and well-being with people. So it's kind of having a different framing as well with it, because at the end of the day, it's politics.
Yes. And speaking of politics, I've got a question here that would be somewhat inflammatory. And then, again, we've had a whole bunch of questions come in. Thank you very much. This is from Matthias van Merveld. Thank you, Matthias. How can you justify or explain that governments put entire countries under lockdown to prevent people from getting infected by COVID-19, but are still selling cigarettes on every street corner? That's a very interesting question. Obviously, the mortality rate of COVID-19 is 99.95% on average across the population. Thomas, how do we make that justification economically? What are governments doing there? What is that right? Are we doing it wrong? What should we do?
Well, I think like COVID really has turned our minds upside down when it comes to those issues, but it has highlighted, I think, an aspect that is so often forgotten when we talk about different diseases, namely that diseases always have a cost, a huge societal cost, and it's not just always about the healthcare costs, because when we talk about diseases, we're just focused on how much does a physician cost and how much does a vaccine cost, does a drug cost, but there are wider societal implications than just healthcare costs. It's also about productivity loss. If people cannot go to their jobs, they have to stay at home, they're less productive, get unemployed, and so on. That's a huge loss to the economy. And I think that COVID has really shown us this. And as a health economist, I'm very happy about this, because we have been advocating for this forever. Because I mean, that's our view. We have to take a broad societal view of what the cost of a disease constitutes.
Yeah, we've run the numbers. We looked at Italy and Spain, and then the cost per quality, and essentially what we found was you were spending 600 million in quality to basically cost 50 billion a month in lost productivity. So it's not a great calculation. Nikolai, where do we balance, you know, the society? I mean, we're allowing cigarettes, but we're doing lockdowns. From your perspective at EFA, what should we be doing?
Yeah, I mean, it's always difficult to argue in these sort of extremes today. Although I'm really, I don't know if the case also applies to Belgium, Brussels specifically, because I'm going sometimes past. So most of the shops are closed, but then sometimes you see these vape shops being just open, which are kind of essential shops. and not only speaking about vape shops. I mean, it's obviously the places where tobacco is being sold, they are open because specifically for, but it's just somehow striking that because vape shop is just this specific shop, it's not like just part of a supermarket or so. But yeah, I mean, I think COVID brings out a lot of the really weird sort of situations that many of the weird kind of situations that our societies have evolved to accept as normal. And I think that's in that, at least in that point of view, it's kind of it's good that this strikes. I think, well, it is again, we just need to look more clearly about sort of, well, and I think this goes back to this idea of, well, how are the environments, are the surroundings around us really enabling health, or are they kind of focused on, at the end of the day, you know, the kind of production, consumption, and, well, let's keep the externalities aside. And I think that's the sort of, that's really the question that I guess this puts very starkly into in light.
We have an interesting question here from Giglioso Spurrier, who works for the Melanoma Patient Network Europe. Thank you, Giglioso, for your question. 1 in 3 every cancers is skin cancer, and although much of it is relatively easy to treat, it has a huge impact on healthcare costs, but screening in various populations has not led to reductions. Would banning artificial tanning devices have an impact? So, cost-benefit analysis, Thomas, again, banning tanning devices, where do we draw the line there from a societal benefit?
Actually, I don't know of any good studies that have evaluated these issues. But what we see is actually tanning beds are becoming less and less common because people have probably seen the message that, you know, going to tanning beds increases your risk of getting skin cancer. But it's just not the main source. The main source is just being outside in the sunlight and not using sunscreen. That's where most of the skin cancer cases that we see come from. And yes, they are easy to treat, but just because they're easy to treat and people will most likely survive those cancers, they still constitute a big cost to the healthcare system.
And melanoma is still very difficult to treat when it does go to stage.
Yeah, melanoma, exactly. But the other ones, like basal cell cancer and squamous cell cancer, they are easier to treat. Yeah.
Nikolai, quickly, any comment on that? Or?
No, I wouldn't have anything to add. So let's maybe.
Okay, that's fine, gentlemen. I will have to say it's hard to believe, but we are almost out of time, ladies and gentlemen. It's striking how quickly a half hour goes. We didn't even get into diagnostic stratification, topic I love, but maybe we'll do that another time. Gentlemen, quickly, just final question for both of you. If we look at the EU process that has been put in place for the evaluation of the vaccines around COVID-19, for example, we've had an accelerated pathway that's actually seen us go from soup to nuts on a new technology in 7 months. Do you see that we should be looking at some of these tools for maybe looking at new ways to look at prevention in cancer, maybe more effective measures, et cetera, that could be accelerated to try and implement, and maybe this should be part of one of the cancer plans? Nikolai, from your perspective, what do you think?
I mean, I think in a way, maybe I will not be fully answering this question, your question in particular. I think that we should take that actually there is. That we should be, that definitely as part of the cancer plan, we should be focusing our efforts indeed on risk factors primarily. And there we need to actually follow quite a lot of the evidence around how to bend risk factors is already out there, despite maybe not always as obviously showing effects on disease. But I think that's sort of still that is in a way at the end of the day the key point, because if you are able to bend risk factors, then you're clear that these risk factors are actually risk factors for a certain disease, then I think you are sort of pretty far there in seeing what actually needs to be done. And I think that's sort of a way of looking at this question, and I really hope that will be part of the prevention pillar of the cancer plan.
Thank you, Thomas. Quickly, from your perspective.
Yeah, I think we have to be, like always when we talk about prevention, we have to be a little bit realistic. There's just no quick fix. We have to take actions now. We should have taken them 10 years ago, and then effects will materialize in 5 years earliest, 10 years, 20 years. But the time is to act now, but we have to be realistic. Like any European beating cancer plan that stretches for 5 years or 7 years, we're just not gonna see the results of the investment that we do now, or that we can do now.
Thank you, Thomas. Quickly, just one final point. Nikolai, Anais Rochon has asked, the Russian study on alcohol consumption, is that available in English, and where can people find it?
Yeah, I actually tried to answer it, but I through the Q&A, but I couldn't. I can forward you the study, and maybe somehow you make it available. But
that would be great. If you could forward that to us, we'll circulate it on the back end.
Please.
Ladies and gentlemen, we are unfortunately completely out of time. In fact, we're slightly over time, which I hate doing. But again, fantastic conversation. I hope we can carry this on again and look at some secondary and tertiary examples of diagnostics. Nikolai, Thomas, thank you very much for a very enjoyable conversation. Mark Sharp and Num, thank you for your sponsorship. And with that, our session is closed. Have a good morning, everybody. Bye-bye.
Thank you. Have a good day.
Morning and
Bye-bye.
Bye-bye.